Welcome. I'm Janet Gatlin. I am the director of Rogers Behavioral Health, and I am your moderator for today's webinar on motivational interviewing, the WD-40 of behavioral change. I am so excited today to introduce our guest speakers, Dr. Sean LeNoue, the Associate Medical Director of Outpatient Services, and Dr. Rob Reff, a clinical director of Rogers Appleton, Wisconsin locations. We welcome both of you. Again, we're so excited to have you today. Before we get started, I'd like to give the participants a quick overview of the format. The webinar is scheduled for 90 minutes and you will receive CE credits. You must be logged into the webinar to get the entire program. There's no need to check in via chat. Your attendance is tracked via Zoom login records. The PDF PowerPoint slides and the list of references will be available to you immediately after the program via email with a link to your personal dashboard, cego.com. In addition, a recording of the webinar will be published on the references section of our website the next day or day for any of you to rewatch or for any of your colleagues to rewatch. So please do share. Our speakers will present today for 70 to 75 minutes. And then following the presentation, there will be a Q&A session. During the presentation today, please refrain from using the chat feature as there will be distraction of the presenters and the other participants. If you'd like to ask a question, please use the Q&A button, not the chat feature, to send a message. So you'll see today at the very bottom of your screen, you simply click on the Q&A button. If you kind of look at the bottom of your screen, there'll be a Q&A button. Please click on the Q&A button on the Zoom taskbar. I will review all the questions that are submitted. Then the presenters will address as many questions that they can during the Q&A portion of the webinar, which will begin roughly at 1:15 Central Time. Finally, we have enabled the closed caption portion of this program today. At the bottom of your screen, you'll see the live transcription button from the menu. You can click on that to show subtitles, to view the audio as text. If you'd like to disable the subtitles, simply click hide subtitles from the live transcription menu. Now I'm going to turn it over live to our presenters. Thank you so much.
Thank you so much, Janet. We really appreciate you being here with us. Hello, everyone. I'm Sean LeNoue, and I'm a physician here at Rogers Behavioral Health, and I have the pleasure of presenting here today with Dr. Rob Reff. And again, we're going to be talking about motivational interviewing, the WD-40 of behavior change, and really thinking about opportunities that we want to share, that we utilize motivational interviewing each and every day in the work that we do here at Rogers. So without further ado, we're going to get started. We talked about the logistics. Here are disclosures, nothing to declare, disclose, as you can see. And we'll jump into learning objectives. So by the time that we're done with this program, participants should not only be able to articulate at least 3 ways that MI strategies can be used in collaborative and client-centered approaches to pursue behavioral change that we do each and every day. But we're also going to identify at least 3 resources that clinicians can use to improve those MI skills and knowledge. So let's jump into it. What we'll cover today, we're going to look at overall scope, motivating interviewing background, next steps, and certainly then, as Janet mentioned earlier, we're going to leave time for a Q&A. So within the scope of the problem, more specifically, we're going to look at a brief overview of our current mental health needs in the U.S. We're also going to talk about provider burnout and caregiver burnout, because that's very real, as we're currently experiencing through the mental health crisis, the opioid epidemic, and the ongoing COVID pandemic. And then we'll also talk about the overall level set in reviewing resistance, apathy, non-engagement, and thinking about ways that then we can overcome that. We'll also get into a bit of background, because who doesn't love a bit of history, right? And think about origin, overview of MI, and current state. and we'll, really try to illustrate this through vignettes and case examples. And then really taking it to the next step and talking about training, assessment, and goal setting that Dr. Reff will be talking more with you all about, and how you can really practically apply motivational interviewing to your practice each and every day. Frankly, it's really at the foundation of what we do in our programs, particularly our mental health and addiction recovery programs. So jumping into it, before we get into MI, a call out that September is National Recovery Month. For those who are not aware, this is a very special month for us, in the US and certainly at Rogers. Started, in 1989, really trying to create more awareness about both mental health and addiction recovery. And really, we're honored to be here today with you. And it's truly a privilege, because we love talking about this. And we also love being able to support colleagues and communities in doing the work as well, so that we can really join together, because we're all colleagues, right? In this taking a stand and really the fight against mental health concerns and illness and addiction, right? These are issues that know no bounds when it comes to the way in which they impact individuals, families, and communities. So thank you for being here today and joining us. Here we go. Let's talk about the scope, okay? So to begin, the level set here, suicide. Current stats in the US, percent of US adults reporting serious thoughts is around 4.5 to 5%. So we're talking about 11 plus million people in the US. And this is an overall increase from the previous year's data. Again, an increase of over 500,000 that are reporting. And those are just the people that we know through report. Far too often, individuals with mental health concerns, depression, anxiety, suicidality, substance use live in the shadows. They feel that they are alone, that they're not able to reach out and to talk to someone about these things. So these oftentimes can be diseases and illnesses of silence. And really, we don't want anyone to have to suffer alone, period. And there's a lot that we can do. We know that death by suicide and suicide attempts continues to increase among adolescents, and that approximately 10% of high school students attempted suicide in 2021. And so, this is alarming. And frankly, unfortunately, these data points fit into trends that are ongoing, and that these don't seem to be one-offs. We know that people are tired, they are stressed, and one of the key ways that we can combat this is to have honest and open conversations with one another, and to be open-minded and supportive of one another. And I think, for those of you who know motivational interviewing, those that may be joining us that are experts, or newcomers, wanting to know more, I think that you will find that motivational interviewing is a really prime opportunity and tool that can be used to help break up stigma, can help break the silence, can help, look for opportunities to look for change, and to help people live better lives, and to help them to move from just surviving back to thriving. But, motivational interviewing, as we know, is not enough. So there's definitely got to be other tools, if you will, in your armamentarium, and that patients and clients are going to need to overcome challenges and struggles. And this is one of those key tools. So current stats for mental illness in the US, we see approximately 20% of adults. To put that in, to real numbers, we're talking about over 50 million people report a mental illness. And this is data that has come out within the past year. We also know that for youth, that 1 in 6 experience a mental health disorder, and this is from NAMI, published this year. And this is an infographic that I think really puts it in perspective to consolidate of really what we're talking about. So 1 in 5 US adults, 1 in 6 youth are struggling with these issues. So, I think it's really important for us as providers, therapists, community members to keep in mind that it's these are significant numbers and percentages. So it is quite likely that folks sitting in the room with you in the office, in a clinic, other places, someone is there. It may even be yourself, right, who is struggling. And there is no shame in that. There's a lot that we can do. Substance use, current US stats, we see that 58%, over 58%. So over 162 million Americans over the age of 12 have used tobacco, alcohol, or an illicit drug in the past month. And this is data coming from SAMHSA, the Substance Abuse Mental Health Services Administration out of the US. We also see that 14 to 15% of Americans, over 40 million, who are over the age of 12, met criteria for a substance use disorder. So again, these issues are prevalent. It's not the one-off case. We know that over 40 million Americans need substance use treatment because they meet criteria in the past year. So the takeaway here is we've got great need. And while this is sort of out of scope, I think it's important to call out too that there's also limited resources, as we know. So all the more reason that we want to help be partners and support to our colleagues and community members, patients and families to be able to utilize evidence-based strategies and techniques to help make a patient and client's experience be most significant and effective. Again, taking a look at national drug data out of the US over the past 20 years, give or take, overdose deaths, what we have seen is that it across the board has continued to rise from 1999 to 2020 across all areas: antidepressants, benzos, heroin, prescription opioids, cocaine, stimulants, and then synthetic opioids other than methadone. And while there are a number of substances that could fall in this category, we're primarily talking about fentanyl here. And you'll see that line is the one with the sharpest increase, the steepest slope here, particularly from about 2013, 2014 on. It has risen precipitously. Overdose deaths related to fentanyl. We're hearing about this all the time. Pill presses, fentanyl being mixed in, laced with pills that are pressed or other substances. And really the aftermath is devastating. People losing their lives. So this is looking at substance use data along with any mental health issue or illness in adults 18 or older from 2020. And this really speaks to the heart of what we do at Rogers with co-occurring, right? Treating the mental illness along with substance use. And we see that adults who had substance use disorder, but not any mental illness, this snapshot, over 20 million compared to adults who had any mental illness, but no substance use disorder, over 35 million. And then you can see this is this Venn diagram, 17 million people who had both issues. And really the takeaway here too is over 73, approaching 74 million US adults had either a substance use disorder or mental illness as of 2020. When we flip over and then look at youth, 12 to 17 years old, we see again, approaching 1 million youth had a substance use disorder. 3.5 million youth had some major depression, an episode there. And then over 500,000, approaching 750,000 had both. And then over 5 million youth total had either a substance use disorder or major depression. And this is just a snapshot of one type of mental illness. There are others, but these data are pretty profound and we wanted to highlight it. Provider burnout. We see that COVID-19 has certainly not aided with provider well-being and has precipitated burnout because our systems, our people are stressed. and pushed to the brink. We see that in this meta review that they looked at a total of 372 studies and then selected 36 overall based off of their inclusion criteria. And overall, the takeaways are that stress was found to be higher among healthcare workers compared to the general population, which may not be surprising. And overall, the takeaway is that when we look at mental illness or significant stressors, that healthcare workers in this meta-analysis and review did not differ overall in their profile compared to the general population, right? So, when we look at associations there, we just see that it's approaching almost 2 times general population, given all that our healthcare workers have been through in the past several years. This is, again, looking at health worker burnout. We see that there's a shortage, 3 million plus of workers by 2028. Physicians, we see that there are shortages. And, we also know that in the ballpark of 20 to 30,000 psychologists, there will likely be a shortage as well here in the coming years. So I think taking a step back too, we're focused so much as we should be on COVID because it's we're still in it, but we also know that this has long been a part of the landscape, and we need to do more because healthcare workers are people too, right? And these are the people that are also serving individuals and patients and clients. So we need to take care of one another. Okay. So now we're going to talk about that resistance, apathy, non-engagement piece. And when you're supervising, a trainee, a younger colleague, or working with a patient, oftentimes we'll hear that, resistance can be high, particularly when there's comorbidity and complicating factors like substance use, mental health. And so really resistance, apathy, non-engagement, oftentimes those are the norm. And frankly, even for clients and patients who do really well, whether or not they have a substance use disorder, there can be slowness to engage as someone warms to a process. Motivational interviewing is an awesome strategy to be able to jumpstart that process, to really level set what an individual's goals are, where they at in the process of change, and how can we help them to develop discrepancy, to roll with resistance along with us in our support for them to really drive towards change. And we know that overall, that when these factors come up, resistance, apathy, non-engagement, that they are not a problem with the patient or client per se, but Miller and Rolnick really say that this is more related to the therapeutic relationship. And this could be an enactment of sorts, or it could be representative in that therapeutic relationship of what that client or patient experiences day to day in their life, but you're experiencing it in your office, in your clinic. And so it's really an opportunity to dig deeper and to try to uncover and highlight more the struggles and then the opportunities for change. And so we look at that discord, we reframe it as it mentions here, and then just bringing up and highlighting that discord, it can really kind of be the norm, and it's not uncommon, and it can really manifest through arguing, interrupting, denying, ignoring, all the things. All the more reason to supportively, therapeutically, kindly keep pushing, keep going. And we should really, when we pick up on this discord, we should see it as this warning light or an indicator overall to really for the provider to slow down, re-examine, challenge assumptions, and really, when you're in it in therapy, to encourage the client or the patient to do the same themselves. And, that's where the science meets the art as well, and how you talk to them. In so many ways, sometimes some individuals are ready, or the style may be more direct. Sometimes there may be more finessing that's needed, or to kind of softly, gingerly approach it, but nonetheless, use it as a signal and a sign to say, slow down, pause. What's this about? What's going on here for me? What's going on there for them? I wonder. And if you don't know, great opportunity to, again, pause, look within yourself, and also work with your client or patient to better understand what it is that they may or may not be experiencing, and trying to better understand. Dr. Reff, did you want to add anything there?
No, I think that's a really good transition for us, Dr. LeNoue. I appreciate that. As always, your passion you bring to the topic. So now we're going to go back in time a little bit, get in your DeLoreans if you know the reference, but we're going to go back to sort of kind of where does this come from? We're not going to spend a ton of time here, but I think it's important to understand sort of how we got to this place. So Dr. LeNoue and I are going to be working I gave control of the slides to Dr. LeNoue, which is hard for psychologists to do. So we'll get our rhythm, I promise. So I was pretty excited when I started doing this research for this talk with Dr. LeNoue, in that I wanted to kind of see if I could find the origins, like where did the first writing come from? So we all know that this really sort of came from Miller. And I was able to find not only the cover of the journal, but the excerpt from the actual journal. So I was pretty excited about that. But we go back to 1983. So many of you were, I'm betting, different places if you even were alive in 1983. But to think about, this is not a new concept. We all know this is not a new concept. But I think even if you go back to the first iterations, it will help us sort of understand how we practice it today. So we go to the, yep, thanks. So I'm using a lot of quotes here, which I usually don't do in presentations, but when Miller sends it, better than I can, I'm going to use his words. So as Dr. LeNoue already mentioned, sort of when Miller came up with this work, we were really in a sort of expert, we treat our patients. If patients fail, it's on them. If they succeed, it's on us. The first group we probably all know is with, quote, problem drinkers. And many of us, I think, just based on who's been on the call and who's been on the line, are working with folks that are struggling with addiction and abuse of substances issues. So this quote kind of digs into what we've already been saying. I'm not going to read every quote to you, but the gist here is failure to become involved in treatment, remain in treatment, comply with treatment, or if you don't get a good outcome, that's not on us, that's on patient, right? And I think what's interesting as we go through these slides is not only was that a sign of the times, but also if you think about it with burnout and you think about it with stress, think about sometimes we get into this negative mind space and we lose that compassion and insight. So not only this is reflective of the time, but I think it's also reflective currently when we're struggling or we're supervising folks that struggle, we start to hear some of this language. And I think that's important to sort of snap us back into the present as well and see how this works. So again, patient does well, the success, look at the great program we offer, right? We'll take pride in it. We've produced these results, right? We changed the patient improved because of us. So again, looking at sort of who owns the success and who owns the failure, right? And I love this last quote, is probably my favorite of these, is all of this is a comfortable attributional system for the therapist. Successes are due to the skill and quality of the counselor or program. Failures are due to insufficiency in the client, insufficiency or insufficient motivation or compliance or insight or deterioration or desire, right? Very clear who owns what in this model. Now we all know, I would hope I don't know all 785 of you, but I'd hope that we're on this call because we don't believe that is how it works, that we're collaborative in how we do this. So if you look at sort of the what made sort of popular, Miller and Roenick in 91, then started to just really widely distribute the work. And of course, it started really in treatment centers and AOD. That was the first iteration. The next one, I believe, that's where I came into play. So that if you look at you can tell how long we've been in the field based on the cover of the book we have on our bookshelf. But that was mine when I came into it. And there's a new generation after us that get the, I think, more fun purple color. But that's sort of where we've kind of proceeded through time, and there's been additions and changes. I will tell you, if you look, please don't look me up on this tool because I don't even, it will not be, it'll be amusing. So this tool is a really fun tool. If you have some of us have favorite authors, like I have favorite authors that I kind of treat like little celebrities that I get excited when they publish new works or other things. So you can look up an author on this tool, and it will give you sort of their impact on the literature of the field. So 198 documents is one thing, but look at the second number on the left, right? Like over 23,000, right, documents, I'm sorry, citations that are in over 15,000 documents. So to say there has not been impact would be, an inaccurate statement, right? So if you're a researcher, like, and you want to disseminate knowledge, it doesn't get a ton better like this in our field. And I will say that what I also find interesting, and Dr. LeNoue alluded to this, right? It's art and science coming together, right? So it's morphing, it's changing. And when I work with supervisees, like, this has evolved over time, right? And we see these documents come out, these peer reviews and articles. So what's nice about this is I'm constantly learning with my supervisees. So we're not coming at it like this, we're coming at it like this, and how are we continually improving to meet the needs of our patients and our systems? So MI approach. So basically what we're talking about, because people will often get confused with what it is and what it isn't, and we could spend a whole time on this and just do that talk, but we're going to get to the real point of this. I think the meat of our talk today was really on sort of what is this next wave or chapter of research and findings, and how do we really sort of get ourselves up to speed. But the basic approach, right, is somewhere between being a good listener, right? So that's following behavior, right? Or following approach, and providing knowledge and counsel, which is more directing, right? The idea is really rooted in empowerment of our patients, right? And that's through collaboration and understanding that patient's capacity for change. Sometimes we understand they have more capacity. We have a person on the floor right now that we're all cheering for, because we see that capacity in that individual, and we're excited and just started treatment, and we're working with that individual to see that they can get there. But it's collaborative, right? It's not us fixing them. It's not, here are the meds that fix you. It's how do we work together to build you up, because we see the potential, right? And it's all based on really respect and this really curious way that we work with people, right? We ask questions. We want it in their language. I tell my supervisees, are those your words or the patient's words? And when they start using the patient's words and they sound like the therapist's words, and it's kind of like this harmony that comes out, that we're like, oh, yep, we're kind of MIing it right now, right? We're getting it together, right? And we really want this process to be, of change to be, the patient have this autonomy over what they're doing and how they're experiencing their recovery or their engagement in treatment. So when is it really useful? So when I work with supervisees, when am I like really working with on these things? Ambivalence is high, right? So ambivalence is the key word. You're not going to get, you're not going to go through an MI training or this MI work if ambivalence isn't discussed, right? So this is the patient. You can talk to the patient on, I'm in these two roads I just don't want to take, right? Sometimes it's like, do I break up with her? Do I not? I used to do a lot of work in college settings, right? Should I be a bio major or should I not? My dad wants me to be a lawyer, but I want to be an artist, right? I don't know what to do. I just am stuck, right? The WD-40, right? Confidence is low is another one, right? It's just too hard. I don't think I can, right? I'm checked out. Desire is low, right? Part of me wants to, but part of me doesn't, right? So we assume in our clinic here at Rogers that all patients have a desire to be healthy and well. All of them. Like, that's a fundamental basis for why they're here. Whether they know it or not, we have to believe that, right? So we're trying to instill that with our patients, right? And importance is low. Well, why would treatment benefit me? My PO says I have to be here, right? Why? It doesn't matter to me, right? But I tell patients, you're still here, right? You're still here. You're not in jail, right? Even, POs tell us to do things, right? But we still have choices to comply or not comply, right? So we're capitalizing on all these elements. So we can't go through, this would be a graduate level talk if we went through all these principles, all these techniques, but I wanted to give you sort of a 20,000 foot overview of sort of what are we talking about. So when we talk about MI and we're either doing trainings or we're doing research or we're teaching or supervising folks, we look at the principles of MI, which should not, surprise any of you, right? Empathy is right out there and right out in the front, right? Developing discrepancy. So how are we kind of helping the patient, the client, the person kind of wedge that open a little bit? Resistance, unless you're Star Trek fans, is not futile. We roll with resistance, right? We work with that resistance. Resistance isn't inherently bad. It's that check engine light, that yellow light blinking, right? And the self-efficacy, right? So what's in our toolbox to do that? Open-ended questions, right? Reflections, affirmations, summary, and eliciting that change talk. When you have that patient start to use that change talk, that's really where it starts to get exciting, right? It starts to, because you hear them taking that on themselves, right? The spirit of MI, collaborative, we evoke change, right? We don't dictate change, and it's filled with compassion and acceptance. Right? So that's kind of big picture. And those will come up as we talk about the different measures and way to assess and train, but I wanted to give you a sense on that. Great resource. I mean, I have to tell you, it's been a while since I dipped back my toes in this work, but I went there and you got 104 studies right at your fingertips to really look at, and not only studies, but vignettes, videos, guides, articles, blogs, and as far as I can tell, all of that is free, so it's accessible. And I'm in no means connected to this organization, but it is an incredible source of information.
All right, great.
So,
Yeah.
Yep.
Thanks,
Thank you.
Dr. Reff. Yeah, I appreciate it. We're gonna tag team here a little bit, and I'm gonna talk with you more specifically about the effectiveness to build on what Dr. Reff has mentioned here, and we're gonna really look at it through the lens of different disorders. But more importantly, we know that when we think about diagnoses, that helps us to conceptualize treatment and kind of approaches. But all of these, I want to be certainly clear and call out that the intent is how can we utilize MI effectively to treat the person as a whole, the individual? Because at the end of the day, that client, that patient holistically is what we're thinking about, and the different factors, right? The MI is not utilized just purely with substance use disorders, right? It's not utilized or effective just purely with anxiety or depression. We can help clients and patients to harness MI, excuse me, and like Dr. Reff mentioned, that change talk that starts to come up that he mentioned in supervision, that we can sort of help their therapists to also help their clients and patients become their own therapists of sorts, and to be able to call out when there's some of that friction, that resistance, and acknowledge it, and then roll with it themselves, keep going. So looking specifically here at substance use disorders, we know that MI is quite effective, particularly when used in conjunction with other evidence-based treatments that we have looked at specifically in alcohol and tobacco use. And we know that it's very useful in youth, but frankly, we know that for all substances, this is certainly from my own clinical experience, regardless of age, regardless of socioeconomic status, cultural background, certainly there can be nuances there, and we want to be very cognizant and respectful and mindful of that. But I would certainly say through experience that you can utilize MI for almost anyone with any struggle, any background. And then again, that science and art marrying together, how you tailor it individually, how you weave it into the rapport and the trust that you build over time with an individual, or how you use it as a springboard to get started with that process of maybe building trust and support is key. And we also know that not only in developing change, that MI can be helpful with sustaining change. And I think that is key, because it's hard enough to help people to develop insight, to help them to develop the motivation and the courage, because it is courage to change and to let go of old ways and old habits. But also, I mean, life isn't easy, right? And life throws us curveballs. And when it does throw us those curveballs, MI can be very effective in helping individuals to continue their journey and path of recovery, to continue to sustain those positive therapeutic pro-social changes that hopefully they've now integrated into their life. So OCD, this meta-analysis noted that there's evidence to show that MI in conjunction with exposure and response prevention can certainly make treatment more effective and efficient. because it's not uncommon at all. And OCD is certainly our bread and butter of what we also treat at Rogers of, there's oftentimes ambivalence, apathy. When we think about the struggles that someone with anxiety or OCD here may be struggling with, it's scary to change because, we're asking individuals to really start to work through processes of letting go of coping strategies that they've developed. Now, maladaptive, right? Ultimately not, necessarily helpful big picture with their overall health and well-being, but by nature of those compulsions, oftentimes those are maladaptive strategies that have historically, oftentimes at least worked to a certain degree, but that overall tend to spiral. So MI can be very helpful there in trying to drive change, and can also help with participation and also helping with engagement as well. And I think you'll find that's a common theme and thread throughout. We also see that in major depressive disorder and alcohol use disorder, that MI, when paired with cognitive behavioral therapy or CBT, certainly shows increased effectiveness for treatment for both subclinical and clinical symptoms of major depression. And really, I mean, when we think about the complex overlay and how depression can further fuel alcohol use and then vice versa, this is a great way to utilize MI to break some of that up and to help further utilize CBT. And we could do a whole different talk that maybe we should do, Dr. Reff, about the strategies of MI in substance use disorder, specifically when tailored with cognitive behavioral therapy, contingency management, other really core evidence-based treatments. So more to come there. We might have a topic for next year already, but definitely we know that this is effective here. We also know that MI is wildly helpful in a primary care setting for our primary care providers who are assisting and treating patients and struggling with depression along with other factors. I mean, hey, the call out here is our scope is much more within the realm of mental health and addiction treatment, but certainly we respect and acknowledge and oftentimes collaborate with our primary care providers and other medical providers, because we know holistically that people don't operate and live in silos, and that their medical conditions, diabetes, asthma, other factors contribute to anxiety and depression, which can also contribute to substance use. So they're all intertwined, right? So this randomized controlled trial compared providers trained and skilled in MI versus control team providers. And what they found, I'm going to read this to you, is that MI training for primary care providers resulted in substantial, significant, and clinically meaningful improvements for their patients with depressive symptoms over time. And so, we certainly, when we collaborate with our colleagues and communities, we want to empower all to be able to be aware of and hopefully utilize these strategies, because they're certainly effective and don't have to be used purely within mental health or addiction treatment, right? MI for all is certainly what we're about here. So medication adherence, when we look to the data and the literature, we find overall that, this is a growing area of study and interest, and I'm really thankful for that. And what we found too, again, with that, helping individuals to develop discrepancy, overcoming apathy, and overcoming resistance, that certainly MI can be helpful with individuals who maybe struggle with medication adherence, because it's not always easy, but helping them to maybe acknowledge where some barriers and obstacles may be, and then helping them to overcome, particularly because this is patient client centered, right? So it's not us, trying to kind of tell the patient or the client, what they need. And it's certainly not on the patient or client, as Dr. Reff mentioned earlier, that if there is a struggle, a failure, or less than optimal result, this is not their failure, right? This is a team approach, and this is really, a sign that we need to do more as a team, and that patient client is a key team member along with the therapist or provider, right? So really helping to support them in that process of change. We also saw that, even utilizing brief motivational interviewing in primary care settings was helpful for at-risk adolescents who are using substances. Particularly here, they looked at alcohol and marijuana, which are some of the most commonly used, along with tobacco or nicotine, right? And so overall, we saw that even these brief interventions, which I think is really key, it doesn't have to always be more. Something is better than nothing. And actually, they found here that it's more than just nothing either. And it's kind of a bigger something, that these brief interventions help to reduce the use and the associated negative consequences, and that longer term yielded positive impacts. And so, I'm a child psychiatrist and an addiction psychiatrist, and I think a lot about the developing brain and overall developmental trajectories, right? Because we want to help everyone, and particularly in youth, when you can intervene and make a positive impact early on, that can potentially reset that individual's trajectory of functioning quality of life over the span of their life. So it's not just here and now today, but improvement over time and for their life. So lots of good uses here. Next, we're going to move on to multicultural considerations, and I'm going to turn it back over to Dr. Reff.
Thank you, Dr. LeNoue. So kind of just want to set the stage for this a little bit. First of all, I am not an expert in multicultural psychotherapy, just to set the frame, and just to acknowledge that I am privileged, white, male, cisgendered, able-bodied. So I'm coming to the lens with my own lens and biases to this work. I will say one of the great things about working with Rogers is we do have experts that do work and research on multicultural approaches to psychotherapy, and really working from a lens that appreciates diversity and the intersectionality of identities. So interestingly enough, I consulted with about 3 of my colleagues on these slides on what language to use to be most inclusive, and I got 3 different answers. All were great answers. So I picked one, and I really went off sort of the Sensoi, I don't know if I'm pronouncing that right at all, 2017, which we'll talk about in a second, way to frame this work. So really exciting, since the development of really the research in 1983 and on, what we've seen is a big growth in research specifically addressing multicultural considerations, working with individuals who've been traditionally oppressed, or individuals that aren't typically represented in the literature base, which is exciting. And not only there's research studies, but there's also, which we'll highlight a little bit today, recommendations for us to be utilizing in our setting. So we're not just cookie cuttering this and not paying attention to who it is we're serving. So that to me is really exciting. And one of the reasons I really wanted to do this research is to see, or prepare for this talk, is to see what new developments have been out there. So can you go back one more on that, Sean? Sorry, Dr. LeNoue. There we go. So MI has been demonstrated to have positive results with what this author calls minoritized people. And we use that term, I'm using this term because traditionally it's a social group that has been devalued in society and given less access to resources. So that's just how I'm framing. There's other ways we could frame it. And so one cultural consideration that has been looked at is alcohol and drug use, utilizing traditional practices from American Indian, Native American, Native youth. So that article is actually phenomenal. I would highly recommend reading that article. This is something you're interested in, because what's neat about that article, it's one of the few that I've read that really integrates what the community is utilizing in their healing and in their cultures, and then using that as a driver to interface with MI and the treatment. It's extremely a really well done article. Medication adherence, that 2015 study looked at cardiac patients particularly in that study, they focused on racial minorities is how the authors deemed it in that. And then alcohol use interventions with folks, Latino folks, in 2011. Thank you, Dr. LeNoue. Really current article, which I'm very excited about, found or really looked at sort of like, if you review all the research that's out there and you look at particularly research that identifies, or I'm sorry, that focuses on the patient or client being a person of color and the therapist or physician or sort of the treating person was a white person, so not a person of color. What are things that we need to be aware of? What do we want to focus on? What are recommendations? And this is, I'd say this is my other second favorite article that I reviewed that I also highly recommend. So these probably won't seem like, out of the blue kind of things, but what I think is important is slow down when we're sort of a white individual, a person of privilege, and we're working with a person of color or minoritized person, because these are really good to remember that we have unconscious biases, we have stereotypes that are implicit in all of us. So a couple things that they really found was a white person working with a person of color, the fidelity tends to go down. And in particular, when you look at the fidelity of executing MI, there were less open-ended questions, and open-ended questions is, I think, one of the more active ingredients in the MI formulation. And then there were reflections, but they were not as complex. And so when we look at complex reflections, it's sort of like, I don't know if you've talked to someone, you've been on a first date maybe, and they say something to you and you're like, oh my gosh, they get me, holy cow. Like that's the moment where you're like, that's a complex reflection. A simple reflection is one of those that's like, oh, thanks, that could be on a greeting card. Okay, whatever, bumper sticker, no big deal, right? So it's sort of the surface level in the reflection and then fewer open-ended questions. Continuing the same study, so what else do they recommend? Well, let's increase our training. So if you're working particularly with communities that are from people of color and you're white, you have a white background, or you're from a privileged group, what they're recommending is increase your training, increase your fidelity, right? That's gonna just be a good rule of thumb across the board. Now, in the sessions or when you're working with the person, what's really important is patient autonomy, right? And if we look at the history of oppressed individuals, it's not surprising that we should be paying attention to that, right? So the patient has the autonomy, empathy and active complex reflection is key. Exploratory questions, right? We want to get the rich sense of the patient experience and be open ourselves to the experiences of discrimination and oppression. So there's a lot in that bullet to take in. We could do a whole talk on that. I probably wouldn't be the person to do it, but we could find, that could be a whole talk, right? And so it's really about not making assumptions and walking in that person's shoes as best you can by having them give you the data, give you the experience to immerse yourself as much as a person who has not lived that experience themselves can get. Okay. Training on people of color, sexual gender minorities, and other minoritized individuals and their experience with mental health discrepancies or disparities and oppression within the context of medical treatment. So again, very specific, but we really want to understand that the experience of someone that has privilege, power, who identifies, at least in this culture, as white, is going to have other opportunities and other experiences, right? And so, something as little as, how we access care or what care we have available to us. Do we have residential benefits? Do we not, right? And even sort of making judgments based on patients' insurance or how they're presenting, right? So we really want to sort of suspend our assumptions and really understand the impacts on folks and their experiences and how they access healthcare. So case study. So we like case studies. We learn really well from case studies. So I wanted to pick something that was relevant to all of you. So you can, I'm hoping relevant to all of you, that you could pick some aspect of this and relate it to your own practice. We at Rogers specialize in really IOPs, intensive outpatient, and PHPs. And so I'm using that example because that's what we do, but I think you can, and residential and inpatient in our other settings as well. In the Appleton Clinic, we're PHP and ILP focused. And we'll talk about depression recovery. I could have honestly picked any of the services we provide to our patients, but DR, this patient really struck me as one that we could use for this talk. So I'm not going to read it verbatim, but I'm going to pull out sort of the active elements just to give you a sense and to frame it. And while this is a particular patient, I will say this theme occurs quite frequently. So the 26-year-old individual, female, with a long-standing history of mental health struggles, particular major depressive disorder, with 2 serious suicide attempts, and had multiple outpatient therapy with limited to no success according to patient. So that presentation, probably for those of us in the mental health field, is not overly shocking. We see patients that have struggled, especially within that age. This particular patient was living with their parents who were supportive. That patient was not able to get work despite, I think, a desire to be employed. And parents were obviously really concerned. They admitted to our DR program, depression recovery program, our partial hospitalization program. And so we really do work really hard at Rogers to make sure we're matching the patient with the level of care they need and what treatment works best for them. So we really thought, with this patient, this is really a good fit for patient. And I think it was, is. And so this all came about after a really serious suicide attempt. And the patient was staying at an inpatient hospital, not one of our, but a community one. And that's only relevant because I think we didn't have that relationship already with that patient coming in, which we're happy to serve patients that come in from other hospitals. But in this context, it was sort of, we didn't have that same, if they were in our inpatient stepping down to us. So patient gets our program, still having some, not surprisingly, high suicidal ideation and hopelessness, and really struggling with all the evidence-based stuff we really enjoy doing here at Rogers and we think are really appropriate to work. So we have this, we're fortunate, this is the first place I've worked at where we have measures with our patients and we can really see how they're doing almost in real time and the severity. And the patient wasn't making significant progress the way like the patient wanted to, particularly, and the family wanted to, right? This takes time, right? And so patient was struggling to engage in group, in the assignments, and really was refusing on meds. Didn't really want to take meds, didn't really feel like they'd help or didn't understand them. And again, really early in treatment. So we have family sessions here, which are quite amazing to watch and be a part of here. And because we really appreciate all the sort of team, we're a team approach, right? Patient's part of the team, therapist part of the team, psychiatrist part of the team, nursing part of the team, the family's part of the team, right? So it's a team. I always say it's a team sport. Rogers' mental health is a team sport, right? So we get the family engaged. And what we start to kind of see here now is pretty dominant father who's concerned about the daughter, who's our patient, and basically says, she has to go to residential. We got to get her into residential. And the patient, not uncommon, says, I'm not going, right? And so father says to the therapist, well, does she qualify? Can we just get her there? She needs to go there. This isn't working. Clear it's not working. Now, mind you, this is like in the infancy of treatment, right? This is like, I think family session, probably day 4 or 5 of our PHP program, right? We're just dipping our toes and really helping the patient understand and getting to know our patient, right? Because this isn't sort of, we meet the patient where they're at Rogers here, and we try to understand their needs and get them a treatment plan that matches to those needs. So really early on. So why are we using this example? I think the next slide will help us. So what do we take from here? Well, there's obviously resistance, right? This young woman was like, yep, sign me up for residential. I'm going today. That's very rare that we, right? That's not usually a response because, right, it's a disruption of the person's life. So usually, the person needs to think about it, what's going on. In this case, the father dictating, oh, you got to go, right? That was a hard no in that moment. And so empathy, right? So the key here is that I always tell the folks that I'm working with is get into the mind of the patient, understand what that experience is like. You're in a family session, you've already failed and it's day 3, according to your father, right? What does that mean, right? So how does that feel to the patient? How do you connect with that, right? And this is the developed discrepancy. There's a really talented therapist we have on our floor. Dr. LeNoue knows her, and she's sort of fresh out of grad school, a couple of years out of program, working on her license that we're working with. And in supervision, and she just made a joke about this, if you have supervision with Dr. Reff, he's going to ask you, why is this patient here in the patient's words? Like, you will not escape a supervision session with me. If you don't know that, you're going to find out really quickly that I need to know why the patient is here. And I don't, why, and even if it's the PO or mom's making me or dad's making me, that's a start, but we have to know why they showed up, right? And so why is the patient in treatment, right? What do they want, right? That's the key. Once we start getting those things, that's where we start to be able to sort of really help the patient develop that discrepancy, understand they have agency, and get them to go somewhere. Like, I've heard the most, and I'm sure all of you have too, why are you here? When you ask that, not in that way, so it'll be, we would be longer on that, but when they say to you, I really want to be a good father and I can't because of my addiction. Wow. That just, talk about making our jobs easier, right? It's not about your scores. It's not about, following this, taking this med, doing this, doing that. It's about, I can get behind that. We can get behind that, right? And so it's about the self-efficacy and helping the patient understand what they can or can't do. And in this example with that young woman, she was being told what to do all the time. She didn't feel like she had control. She didn't feel like she had a say. She didn't feel like she had the agency or the ability. She was broken in her own mind, but she wasn't broken in our mind, right? And that's what was key in that instance. I don't know, Dr. LeNoue, if you want to, this patient pretty well too, I think. Or you've done similar.
You said it so well, Dr. Reff, and what I so appreciate is your passion, and you hit the nail on the head. Why is this person here, right? Because when we can get to that and then really get to the agency piece as well, when people feel like they're in the driver's seat of their life, and particularly in their treatment, that's where the magic happens, right? Because then we become a team and we can get some really good stuff done. So thank you. Yeah, agreed.
Yeah, of course. There's a couple of things because I took some notes. So just to give you the sort of what happened next, because I think it's always important. The therapist responds to father in a very advocate way, like to the patient, because she's our patient, and resets expectations about where we are in treatment, where we are in process, right? Your daughter's been struggling this for a lot of time and she's on day 3. Like, we got it. We got it as a team, right? Working on treatment plans and goals. We're just in our infancy. We talk about sort of how change works. So empowering the patient and now the family to understand, like, Rogers isn't about us doing stuff to you. It's about us working with you to create a plan for treatment to get better together, right? And 3 days of knowing you is not enough to understand your 26 years on this planet. And so stay with us. The longer we know you, the better we know you, the more we hone in and we get to be laser focused on helping that patient as a team. So we talked about medication resistant and really help the patient. That came from, I don't want people to tell me what I have to do. I don't want doctors to tell me how I'm going to get better. Once we explained the medication in a way the patient understood, and they understood why it would help them and how it would help them, guess where that resistance came down? It wasn't us doing it for us. It was the patient choosing to engage in the medication as a part of the treatment because of the benefits. And we also empowered them. You have a choice. Once we even tell people you have a choice, comes right down, right? Therapists really validated where the patient is and what they want long-term. In this instance, the patient wants out of the parent's basement. They don't want to be living with the parent. They want to have a job. They want to be successful. We identified those things. They want to be in a healthy relationship with another person. Those were all like those accelerants to the treatment, the catalysts that we had now that we didn't have, that the therapist didn't have, that did a great job with this. And we talked about the residential program, and none of us thought it was time for residential except for the father. And that came from a place of love, right? The father wasn't being, malicious. The father wanted the best help, but, the patient needed to decide what they wanted along with the treatment team. And ultimately we kept them in the PHP program, and the patient you could see the blossoming autonomy and right. this is not, I'm not trying to sugar, like, this is one example I picked out for here. There's a struggle. This is, this is a struggle, but this patient comes to mind because it really was about the MI principles, right? So what else did we use here? In the MI techniques, if you want to just advance one. Change talk was a big deal. We're constantly changing, not going in the past. How do we move forward? How do we get there? The open-ended questions are the only way we're going to get the patient's words on what they want. Collaborative and really getting that why, right? We're not prescribing the why. If we said, we're going to help you get out of your parents' basement, oop, that's shame. Like if we came up with that idea, if the patient comes up with that idea, now we're collaborating, now we're a team, we're going to get you the skills and the tools you need. So that was the case example. I love case examples. So thank you for listening to that. The credit goes to our therapist who's doing a great job. She's amazing down the hall doing work with patients right now. So, all right, moving on then. So just want to talk to you about training, assessment, and goal setting. So you can go next slide. Yeah, so there's a ton of really interesting stuff. And what I want to frame this with is it all depends on kind of what your needs are. Like if you're doing Fidelity research in a fancy lab in a big university going for $1 million grants, that's a whole nother bucket, right? People will ask me, do you need to have a license? You need to be an MD, a PhD, what do you got to do this work? That's not what we're talking about here, right? So I've had supervisees tell me, use some of that MI stuff on my boyfriend. Worked really well. He's doing the dishes finally, right? So we're talking on a continuum, right? We're talking like, if you want to do treatment control studies and SAMHSA, okay, great. If you're in grad school, that's another thing, but these principles can be incorporated into a lot of what we do and how we do it. So a lot of meta-analysis approaches. So we can go on to get some of the meat of this. So interesting study here, not that 2 years old, healthcare professionals, big meta-analysis, and looked at the tools that were used in terms of training and supervision and sort of what research was around them. So this is for you get the slides. So this is not, I'm not going to go through all the acronyms and the reading, but I want to tell you, these are the Fidelity tools out there. So these are the tools available to you. And I will tell you, I have one that I'm biased to. I don't know. Well, I don't have, doesn't matter, but I use the tool informally. I will print a page from that tool and give it to the supervisee and say, hey, let's see how you're using these this week. Let's see where this comes up or where you could do better. And we have really talented behavioral specialists, like BSs, this is the, I can't get that out of my head, but who just are like soaking this up. And then they go in there like, oh, I tried this thing, or I tried that, or and so these tools you can use in that context all the way through to Fidelity. So when we talk about these variables and the tools, what they're looking at is the characteristics of the administrator. So each tool is going to say, if you're going to administer this tool and you want to use it to its full extent, this is kind of the administrator and what they should look like. It goes through the techniques and the principles. That it looks at the specific types of validity of the tool. And this is where you can get really fancy if you're a stats nerd and really look at sort of like, what kind of validity are we talking about, right? The adequacy of the training to meet the goals, and then the reliability, again, if you're a stats nerd. So really looking at, are these reliable results we're producing, and then are they valid? Or they have the results we want in terms of efficacy training. So I really like this slide in terms of, it gives you a sense of how deep you can dig, right? So if you want to pick one of the sort of columns or the groups of columns, right, and you really want to work on empathy in your supervision of yourself, you go to that column. Those are the tools that you can utilize to really dig into empathy, techniques, the spirit of MI. So this is just a really nice graphical overview. We're not going to go through it all, but that maps on really nicely to the MI principles and techniques and spirit. So what were the findings of the researchers? Not surprisingly, you pick the tool based on what you need. Some tools are broad, some are focused. The feedback of the tools can be broad or very specific, or very sort of laser targeted or broad in terms of the MI. You want to match the tool to the developmental training level of who you're working with. These tools are all open source as far as I know. I've downloaded all of them, so they're completely accessible in the public domain on that MINT website that we showed you, and we'll show you again. More of the tools are developed towards folks at sort of new entry-level sort of clinical experience or training, which is a testament to MI, right? This isn't something like you have to, really specific experts can do, right? And then, so we're not going to go through these, except I wanted you to have them in your toolbox, right? So each one on the top will be sort of what tools to use when. So we're going to go through these really quickly. But if you look at sort of high administrative burden on this one, if you have limited resources to dedicate it to ongoing assessment, these are quick and sort of easy ones to execute. If you're really into psychometrics, go here. And then these I thought were interesting to pull out because certain tools had certain really sort of special things associated with them or nuances. So if you want the perspective of the client, that's the instrument. If you want functional dysfunctional skills, which really give that feedback to your trainees, that's the one to use there. If you really want brief short feedback, that's the one to use there. Micro skills, that's interesting for me if you're really focusing on a specific goal with a supervisee or yourself, like I want to improve X, Y, or Z. These are the tools to really dial into. Metrics for proficiency, so really how are we seeing improvement over time with our supervisees and ourselves. And then some training aspects. This is your other authors from 2014. Not surprisingly, MI skills decline over time when we're not using coaching or feedback or getting further training. So all of you on this call, you're getting further training, which is awesome. Authors sought to understand what really are, how do we sustain over time the fidelity and the outcomes. They looked at 1,700 studies, got it down to 21 in their analysis. So here's what they found. Overall, post-training, expert supervision was moderate in their studies, so you didn't have to have a ton of it. They found on average 3 to 4 contacts, so that's basically a supervision session or connecting with someone that knows more or as much as you. And they said about 5 hours was needed over that 6-month period to maintain effect. So we're not talking about, you got to be in months and months of training, right? And I feel like these are sort of the check-ins, right? These are sort of the, okay, am I really doing this? Am I really doing the spirit of MI and following these things? Dedicated feedback and coaching was key. And then the focus from only initial training. So a lot of times folks were going to one thing they paid for one day and then did nothing else. And what the authors are suggesting is let's keep ongoing learning and keep it in your portfolio of what you're doing. And let's see, again, another meta study here that I think is got some really good stuff in it. Again, huge analysis of the articles coming down. This really looked at training in terms of specific students. So how do we train students? The largest proportion of students were in a medical school setting, and the MI training varied from 2 to 40 hours. So the aggregated effect size based on these components, which should look familiar to you. Give you a sec to read that, and then there we go. So the significant moderating effect. So, what basically caused it to work or not work? What was the thing that we manipulated was found for length of training. Most of the trainings were relatively short. Longer trainings did not lead to increase of mastery of skills, but rather familiarity of the material. So here's where it gets interesting, I think, for all of us. Empathy and open-ended questions were important contributors to the aggregate effect size. But again, that's not unique to MI, right? We should be doing those things in our normal practice. MI adherence and reflections to question ratios are not, MI adherence and reflection to question ratios are items not as widely covered, but deserve focus. And this is sort of the take home. We need a phased approach to training. So you want to develop your base skill, like understand what we're doing, and then you want to apply those skills in life with your patients, with your trainees together. And then that's where sort of the magic happens. It's the initial learning and then applying it with your patients and with supervision and consults if you're not in a supervision kind of environment, okay? So ongoing supervision and practice are key. Not too surprising, but important to hit back on. Dr. LeNoue, I'll turn it back to you.
Thank you so much, Dr. Reff. And I love that you really pulled that apart and took a lot of complex data and studies and really just synthesized it to make it much more bite-sized and to be able to have that practical application, as you mentioned too, of like, if you want to work on this, go here. You want to do this, go there. If you're supervising, this is what you need to look at. So definitely want to save time for questions here, which we're going to get to in a few moments. But to summarize what we've talked about today, we know that motivational interviewing certainly is an invaluable tool, and it can be used and utilized to treat patients and clients with a variety of different needs, as we have seen. And, you know, it's important, as Dr. Reff mentioned too, that we think about individual tailoring of these techniques and of your skills to meet the client or the patient where they're at, and that we're treating them as a whole, and thinking about their identity and background as a whole as well, and that we're being sensitive to the person as a whole and really to meet their needs, right? And we know that given these ever-changing and complex needs, adaptive therapeutic strategies noted here, like MI, is really, I would argue, vital in assisting with creating change. Now, MI is not the only principal strategy technique, right? But it is certainly one that has been well studied, as Dr. Reff highlighted, and that when we think about the way that that knowledge has been disseminated, put into practice, utilized, there is no doubt that MI is really key to helping with creating change. And then to close too, I think, as Dr. Reff so eloquently put it, in looking at the literature as well, not only training is important, and frankly, we also know that, you know, the deeper you go, the more expertise you can develop, but it also doesn't take a ton of time and experience to really get your feet wet and to be able to use these principles in an effective way. But that training's not enough, right? We know that practice is where it's at, and that with continued utilization over time, that's where we see that clinicians, providers really create some of the most impact. So again, I want to thank you for your time and your attention here today. It is certainly a pleasure and an honor to be able to talk with you about this. So I think at this point, what we can do is open it up to some questions and some discussion, please. Yep.
Yes, so thank you. Just really quick, I wanted to say again, if you have any questions, please go ahead and use the Q&A button, not the chat feature that's on the bottom of the Zoom taskbar. We'll go ahead and try to answer as many questions as possible in the time allotted. And, you know, we may combine some similar questions. So if your question is in this chat feature, we're going to definitely go ahead and combine as many questions. And by all means, if we don't get to your question today, please feel free to message me afterwards. I've already gotten some messages from those that I know personally. You can message me or email me at rogersbh.org, and we'll try to follow up with you. But let's go ahead and get started on some few questions. So the first question, I saw them on the chat, and we have some other questions here that we've had emailed to us. You know, motivational interview might not work for everybody. How would you know if it isn't working, and maybe if it's really not the best fit for someone?
Such a great question. I can get us started if that's okay, Dr. Reff, and please jump in at any time. We can make this conversational. No, you're right. You know, treatment is not one size fits all, and certainly techniques and approaches are not either. What I would say that I think the literature certainly supports, and what I have found in my own clinical practice, is it's really about just getting to know the individual. And that takes time, and it doesn't take a lot of time either, right? So I think that if, you know, someone feels, you know, a therapist provider feels that MI could be useful, I would give it a try. I think it starts with making sure that an individual is comfortable and competent at being able to utilize the skills, and also understanding, you know, that therapy is much like life. It's all about what you do next, right? And so, you know, really sticking with Fidelity to the model, and then also I think talking, with your client, with your patient overall, because what inherently goes into this process, and that we did not explicitly state here, is you're really in many ways trying to elicit change by looking at many times values, goals, really looking for what is important to the individual and then going there. So in some ways, whether you want to call it motivational interviewing or not, really what this goes back to the heart of is patient, client centric, informed care that allows those individuals to have agency and say. And then if you or they feel like things are not going in the direction that you want, again, it's not about us doing something to a patient or a client, and it's not about their, quote unquote failure or whether or not they achieve success. It's really about, as Dr. Reff put it, I love it, this is a team sport. And so how are we coming together and reevaluating, looking at where we're doing well, where there's more to be desired, and how are we going to go about that? I could certainly say more, but Dr. Reff, I don't know if you have other thoughts along those lines.
So I'm going to answer it as if you were my supervisee and what I would say. So if the gist is really about it's not going to work for everybody. And I would challenge my supervisee to say, what do you mean by not work? Let's talk about that, right? So what I got my start after grad school working on college campuses trying to reduce high risk alcohol and drug use. And what I told myself then, and I still tell myself now, is there were so many wins that I didn't know about or see that sustained me while getting in arguments with 19-year-olds on the healing effects of marijuana. So they weren't arguments, but it was a challenge because they would come in loaded to shoot me down. And, I would just disengage from the argument with them, and they've never had an adult or someone with a degree disengage. I'm not going to fight you on that. There's a reason you're using. Like, okay, that's okay. What do you want out of this? What do you want? And if it was nothing, that's okay. Because the hope is, and this was the cheeky joke, is I would be like, we're just planting the seeds, wink, wink, right? So when you want help, we're here, right? So it's, again, stage to change, understanding where they're at. And what do you mean by working? Like getting the outcome you want, or meeting the patient where they're at and hopefully getting an outcome down the road, or at least opening the door a little bit for them, or at least having a validating experience with them, right? And at least having someone that listened and wanted to hear why. We would joke, you're forced to be here. They were mandated students. I'd be like, you're forced to be here. I'm forced to be here. Let's just make the best we can out of this, right? And sometimes that's enough, right? So yeah, it's not going to work for everybody, but let's define what that means and reset.
Thank you. I think that's really helpful. We have quite a few questions around motivational interviewing in younger children. So if we could talk a little bit about, how young of an age can motivational interviewing be used with? Can it apply? I have some questions around younger age, around 5 or 6, but even, younger children. So if we could talk a little bit about your experience with motivational interviewing in younger children, that would be great. Thank you.
Yeah, happy to do it. I think there's sort of, well, this is I think a really important question, and I think the response, the answer is sort of multi-layered, multifaceted, because, there's what the literature shows and says, there's clinical practice, and then I think there's the spirit of MI and the spirit of what we're trying to go after and do. So from a literature standpoint, you probably see some of the most support and work done in the literature with adolescents, older age children, and then adults, right? But certainly there is some data out there about younger individuals. What I would say is this is, a technique that I have used in my work with older children who sadly, unfortunately, were using substances, and sometimes even some pretty significant substance use. but even individuals not using substances who are younger, and I think to the question of like, even, earlier childhood, middle childhood, I think when we look at the core principles and strategies of MI, and then when we look at the spirit of MI, of really gathering the perspective of the individual, I think we're all doing that, right? It may not always be full-blown MI, but certainly, why are you here, as Dr. Reff said? That's the basis, the entry point, and then helping and trying to understand as well what that person's perspective is of what is happening for them in their life. What are their thoughts about being in some sort of treatment if they are? And what do they want to get out of it? What do they not want to get out of it? And why? That is frequently a question that we will come to in motivational interviewing, is why. And also the fact that, you'll hear when you get into the skills of, someone will talk about, well, 0 to 10, 0 is the least motivated. 10 could not be more motivated. Someone will say, I'm about a 7. The response to that is, that's fantastic. Awesome. Why not an 8 or 9 or 10? Why? And on the flip side, why not a 3 or a 4? 7. Tell me about 7. Why? Because that's really, really important information. And so again, that's just one small example of really trying to really get in and help this person to develop autonomy, agency, and be in that driver's seat. The last thing I'll say, and certainly open up to Dr. Reff as well, is developmentally appropriate, right? Like, you need to be able to translate these concepts, terms, approaches into a developmentally appropriate, palatable sort of way, if you will. Because as we know, you're not going to talk to a 5-year-old the same way that you're going to talk to a 50-year-old. So I think helping it to be meaningful to the individual is always key. And I have frankly yet to find a clinical scenario or non-clinical scenario where I couldn't tailor these principles and techniques to be able to better understand, where someone is coming from, and then also to utilize to better help support in where they want to go. So those are my thoughts there.
I would just add, it's about working with the parents as well, right? And applying this and giving them empathy. And, sometimes it's the parents' day, it's their darkest day for what's going on, because they care about their child so much. So these principles also help, I think, in the parents in empathy, compassion, open-ended questions, understanding what's going on, understanding their struggle, because they're struggling along with the young child. The other piece I'll just point out with children is, and I'm not a child psychologist, but I love to sit in our child unit, and I'm always shocked by when a child, especially in a group setting, will reflect to another child naturally these MI techniques. And so sometimes we don't give them credit, and I just listen and I'm like, oh my gosh, that was an open-ended question. And you're, wow. Like, we had a group, we had a combined group of some older kiddos and some younger kiddos. The younger kiddos were asking open-ended questions to the older kiddos in a therapeutic sort of like healing way, like, oh, I think you're struggling. What's going on today? Like, how can we help you? Like, and I'm like, oh my gosh, like, you can tell you're in a place of healing, because if you're in a place of healing, we default to these things. It goes back to that, right? So, obviously there's limits. If someone's acutely psychotic and might be able to be grounded, or, right, there's limits, right? But we're talking very specific, limited things. People who care about other people in a setting that encourages that, this will happen. So.
Thank you. That's also important. I would say the next set of questions that I'm seeing a lot of ask is for, really learning how to deal more effectively with denial and resistance from clients, how to handle their frustrations when maybe change is slow. So any more suggestions or, any more feedback on those kind of questions?
So yeah, I think that's, as you have age and you have more time working with patients, you kind of get this sense when you're working with newer clinicians of just slow down, just meet them where they're at. Today's maybe a resistance day. Today's maybe they're struggling. Validate the struggle, right? Validate the struggle. This is not easy, right? And the nice thing about our setting as well is patients get, when I was outpatient, my patients never cross-pollinated the healing with each other. Here at this setting, one patient might be struggling while the other isn't that day, and sort of you can see the hope with one with the other, right? And to point that out. And to me, that's sort of one of the things, is sort of understanding that if we're not getting the results we want, and it's not going quick enough, it's because usually we're wanting things to happen too quickly, right? We're not giving the space. A lot of MI is about slowing down and giving the space, working with the silence. There's a great researcher and colleague, Dr. Jason Kilmer, who works University of Washington, who's one of my celebrity research folks. He will sit with silence until patients give all their whys. And that, because they'll usually give one why. Why do you use marijuana? Tell me about what you're getting out of it. Why are you using marijuana? And most of us, when the person says, help me relax, they go, okay, next question. He will just leave the space for them to give 14. He did a research article on this. When given enough space, the amount of time patients would give and get to the real reasons, you eventually got there. So for me, it's about slowing down. It's okay, meet them where they're at, but really sort of watching the pace. Is it our schedule or their schedule? Are they seeing the progress, or is it that we're not seeing the progress, right? And sort of just try to slow down. That's the biggest thing I can tell, and be human with them, right? Dr. LeNoue, anything you want to add on that?
No, fantastic job. And I know that we're right at time here in a moment. So Janet, was there anything else before we move on to resources?
Yeah, so we are out of time. So just a couple housekeeping items before we wrap up. This is all the time we're going to have questions for today. Just a reminder that if we did not get to your question, again, please feel free to email me, send any questions. This webinar will be available at rogersbh.org, which is on our research session. You can again follow up with any resources on our resource session. Many thanks again to our presenters today. This was a wonderful webinar. So we thank you so much for your time today and taking away time from your clinical practice and sharing this valuable insight with us. Collaboration is essential for all of our patients to be on the road for recovery, especially during Recovery Month. I think this was just a great way to celebrate Recovery Month and share some of these insights and tools and tactics for clinicians to use. So thank you. Rogers provides services throughout a growing network of communities across the United States, wherein multidisciplinary treatment teams are ready to partner with each and every one of you. Our outreach representatives are looking forward to connecting with you about our practice, and they're happy to answer any questions. So if you are unaware of your outreach representatives, please feel free to email me. I'm Janet Gatlin, and I was on your contact for on your email. So please reach out to me if you have any questions. I've already gotten so many messages throughout this saying hi. So it's good to see some of you or say hi to you. Anyway, before we conclude, if you would like to ask our presenters to share a few recommended resources on the topic with our participants. That about wraps it up for everybody. I'd like to remind our participants that for those of you that met the required commitments, you will be eligible for CE credits. Within the next 30 minutes, you will receive an email with a link and a personal dashboard with ce-go.com where you'll be able to access. It's a PDF file with the PowerPoint slides and the handout and a complete list of references. For those who've met the time requirements to qualify for the CE credits, you will need to complete the evaluation to download your certificate for the event. Certainly, if you have any questions about the follow-up email, please contact the support at ce-go.com. And again, we thank you so much for your time today. On behalf of Rogers, we look forward for you to participating in our next upcoming webinar. We'll be sending out that information shortly. And we thank you so much for partnering up with us today. So I appreciate your time. Thank you so much. And thank you both, Dr. Reff and Dr. LeNoue. Thank you. Bye, everybody.